a bulla, which is one we will talk about, a large fluid-filled blister, crusted, which means kind of dried, or an exudate. You can see the pictures. Ecchymosis is a large confluent area of purpura, and then next to that you see purpura, which is large macule or papule of blood in the skin, which does not blanch on pressure. And then along those lines is also and then we'll go to erosion. You can see an area of skin that's kind of eaten away at itself. Excoriation is scratch marks. Papule or small papule is a very small circumscribed, it's slightly raised typically. Petechiae or pinpoint macule of blood in the skin. These are usually blood vessels. Flack is a large, flat, topped, elevated, palpable lesion. And then we talked about purpura. Pustule is kind of yellowish, white, pus-filled lesion. And then scaly is when it's visibly flaking, shredding. So these are pictures. So when we talk about them, if you're unsure what I'm talking about, you can always go back to the slide when I send you the PowerPoints if you want, but it's a good resource just to kind of get us all on the same page. So first disease I'm going to talk about is erythema multiforme. And here we're just going to talk about like pretty basic, just a few different things. And this week we're talking about all things that are non-infectious, so not typically associated with viruses or bacteria specifically. And then next week we'll dive into infectious causes of rashes. So this week, non-infectious. So erythema multiforme, and here's some pictures of it. You see kind of that target lesion where it's darker in the middle. It's kind of light and then a little darker and then light again. So this, we call it a target because it looks like a target. So erythema multiforme is an immune-mediated disease. It's typically self-limited. It involves the skin as the predominant organ system involved, and it's characterized by these target lesions. It can have erythema multiforme major, which involves all the mucous membranes, and then minor, which does not involve the mucous membranes. Because the disease itself doesn't usually cause that many serious problems, it's much more serious when it does involve the mucosa because it can lead to more serious complications. It can be precipitated by various medications. These are typically antibiotics, anti-epileptic medications, non-steroidal anti-inflammatory drugs. Those are the ones notorious for causing this. It can also be brought on by vaccinations and then certain illnesses, so herpes simplex virus or other viral illnesses. And then it can also just be idiopathic or just come on without a reason. There are some genetic predispositions that people have to developing erythema multiforme. And then some conditions that are associated with it. So diseases would be like an inflammatory bowel disease, hepatitis C, leukemia or lymphoma, or a solid organ malignancy. And having any of those things puts you at risk for developing erythema multiforme from these other causes. Systemic symptoms of erythema are present in a fair amount. It's kind of a general fatigue, malaise, myalgias, or fever, but those are likely from a precipitating virus rather than the rash itself or the disease process itself. It's probably the thing that brought on the erythema multiforme that causes those. The cutaneous lesions will start in the periphery and then spread centrally, and that's on the body, so palms and soles, and then go towards the trunk of the body. The distribution is usually symmetrical, and then there is a preference for extensor surfaces. The rash can be quite painful. It can be pruritic or appear swollen, and these patients are fairly uncomfortable, which is why they may be presenting to you. And early lesions are going to be round, and then they're little papules, like we talked about, and then they'll develop into those target lesions. So it can be harder to diagnose in the early form. Lesions in the mucosa will often blister and erode because of the nature of the mucosal surfaces, and they're usually in the mouth, but it can also be in the urogenital area. These can be really painful, and that limits people's ability to take anything in, causing dehydration, malnourishment, and so that's where you can lead to more complications with this disease. This diagnosis is based on history and physical, so identifying that rash, so that's why it's an important one, because there's not really a test that's going to tell you that this is erythema multiforme. And there are other disease processes that cause these target lesions, so getting a good history and then knowing the rash. So you can and probably should get some other testing with this disease, so CBC, LFTs, ESR, and then look for infectious causes. You can biopsy the skin, and there are certain characteristics they can look for histologically to indicate that it's erythema multiforme, but that's not going to really affect our ER diagnosis because we usually aren't going to get those results back. If a person has had this multiple times, they keep getting erythema diseases because it's not that normal. There is no treatment for this unless it does involve the eye. Then you should consult ophthalmology because these can cause permanent eye damage. But you can prescribe topical steroid creams or antihistamines, and then those can be really beneficial for the patient's symptoms. So that's erythema multiforme. And then just to show you one more time, so that's what the typical lesions will look like. So just remember those target lesions. Next, a much more severe disease, so Stevens-Johnson syndrome. And so you can see this is fairly extensive. You're going to have some of the bulla. You're going to have a lot of erythema or redness. You're going to have some raised lesions. The skin looks just quite severe, and it's extremely painful. So Stevens-Johnson syndrome, and I'll use the abbreviation SGS sometimes just because it's a long one, is delayed hypersensitivity reaction involving the skin and sometimes the mucous membranes. This occurs, it's usually you get death of the keratinocytes under the skin layer, and then that causes a separation between the epidermis and dermis. This is how you get that blistering appearance. The dying cells then provoke recruitment of cells that perpetuate inflammatory process, which leads to even more necrosis and cell death, and just kind of becomes a vicious cycle. Stevens-Johnson syndrome can come on from multiple things. It can be from infectious causes such as herpes, AIDS, hepatitis, mumps, group A strep, diphtheria, mycoplasma pneumonia, or typhoid. And then oftentimes it's drug induced, and this is a lot of times where we'll see it or where we think of it. So antibiotics, and there's an extensive list of antibiotics that can cause this. Anticonvulsants, antiretroviral medications, allopurinol, sertraline, and tramadol are like the most characteristic and most common to cause these. It can just be manifested from malignancy, and then it can be idiopathic. Stevens-Johnson kind of has it's a scale or a classification system. So Stevens-Johnson syndrome is going to be less than 10% body surface area involvement of this. So if you see it on, just an extremity, or if you see it on the chest, once it gets to 10 to 30% of the body surface area, you would kind of indistinguishable between Stevens-Johnson syndrome and toxic epidermal necrolysis. Once there's 30% or more body surface involvement, you have toxic epidermal necrolysis. And, it's a little nuancy, but it does change your management. But just remember, anybody with even that you're seeing with Stevens-Johnson syndrome, it can progress. It can progress rather quickly. And especially if you are unable to immediately identify, or in some cases eliminate the agent or the thing that brought it on in the first place. So kind of be on high alarm for all of these patients. The presentation of this, so typically you're going to get a 1 to 14 day prodrome. So patients will complain of not feeling well for 1 to 2 weeks, of fever, sore throat, chills, headache, malaise. And again, that might be kind of more the disease or process that brought this on. And then some people will have some GI manifestations like vomiting, diarrhea, abdominal pain. And then the skin lesions will come on abruptly. So they usually starts with a small area and then spreads very quickly. The rash will begin as macules that progress quickly into papules, vesicles, the bulla, plaques, or erythema. And the center of the lesions are vesicular and then necrotic. So kind of like the erythema multiforme, they'll be target lesions, but they'll progress more to that like blistering stage where they look severe. The bulla can rupture, and that leaves you with your lower layer of dermis. The epidermis kind of sloughs off. And when that dermis is exposed, obviously increases your risk for insatiable losses of fluids, and then leaves you at high the soles, the dorsum of the hands, and all your extensor surfaces. So once you've developed rashes, they'll usually last for 2 to 4 weeks, and they can progress over that period of time. And like I said, if you're unable to identify or eliminate the cause of the Stevens-Johnson syndrome, they can last for longer. If there's involvement of the oral or mucous membranes, those people are typically going to go right into the toxic necrolysis, toxic epidermal necrolysis category, and then it can be more severe because they will slough off. It makes it very difficult for them to eat or drink. You can then also get complications from that. The swelling can lead you to having airway compromise, if there's any like swelling in the mouth or the esophagus. And then you have an airway problem. So that's a major concern. If the patient comes and has a fever with what you suspect Stevens-Johnson syndrome, have high suspicion for a superimposed cellulitis or infection because of their increased risk for that with the epidermis left off. So like I said, complications of this, the superimposed cellulitis is big. You can get ocular involvement. So if it's starting to involve the eye, and that can lead eventually to blindness. So if you see any ocular involvement, you should immediately call ophthalmology. You can get esophageal strictures or tracheal bronchial shedding, which results in respiratory failure. So anything in the oral airway you have to be highly worried about, and these people usually need to get the assistance of anybody who handles burn, or if you have dermatology, but they aren't usually the ones dealing with these critically ill people. So a burn doctor to keep an eye on the mouth and then the airway. If it can lead to you can get renal involvement from Stevens-Johnson if it goes in, and then it can lead to kidney failure, and you can get a lot of scarring or discoloration from severe Stevens-Johnson. So the diagnosis is clinical. So this is a clinical diagnosis. You should be able to recognize this rash and know that that's what you're dealing with. You can get skin biopsies. They can find some histological findings, but again, we're not getting histology and doing skin biopsies in the ER. So you got to be able to identify this clinically. You should get labs on these people, absolutely, because you're usually going to need more than just the ER stay. So I would get a CBC, look for elevated white blood cell counts. You can look at, I didn't write this, other markers of inflammatory markers, the ESR or CRP. You should also get blood cultures, a wound culture if you can, if there's anything that looks concerning for cellulitis, urine cultures, and then if needed, an endoscopy or bronchoscopy to see the extent of any oral involvement. So for the treatment, it's supportive, and most of these patients, especially if they have, over 10% of body surface area involvement, are going to need admitted to a hospital, usually a higher level of care because they need to be monitored closely for developing signs of infection, for airway compromise, and for fluid replacement. So if you can get somebody who has experience with burn patients, you treat this in similar fashion to burns. You got to make sure that you're giving them adequate fluid, because if their skin is sloughing off, they're going to lose fluid. and then replacing electrolytes as needed. If you can, get a history on these patients if you have the time, if you can, like find out if they're on a medication that is suspicious for causing this, or if they've had a recent illness. So try to identify what may have caused this to begin with. And then manage the airway as needed. If you're concerned that there is an extensive amount of oral swelling or, airway sloughing by the time you see them, these patients may end up needing intubated because the swelling and pain can get worse. But this needs to be a delicate airway and have somebody experienced do it, because any manipulation of an oral wound or an open wound is going to cause possibly bleeding or increased swelling, making the airway more and more difficult to get with each attempt. So, be decisive and then have somebody experienced if the patient does go down that route. If you have toxic epidermal necrolysis, there is treatment with IVIG if that's available, so you can use that. So that is, and we'll do one more picture. This is, and like the guy on the right he definitely has toxic epidermal necrolysis. There's an extensive amount of skin involved, so this would need to be treated as a burn. And then remember, pain medicine, it's very painful, so treat their pain. These are just some examples. So drug eruptions that involve the skin, can kind of categorize them into 4 types. The first is type 1, which is IgE dependent reactions. So this is your more common, like we call urticaria or the angioedema. It's like an typical allergic reaction, which we see these probably by far the most commonly from other things, but not always from drugs. But yeah, that just like a typical allergic reaction rash. Type 2 is a cytotoxic, so that results in hemolysis and purpura. Eruption is immune complex reactions, like in a vasculitis. And these ones, you will get a serum sickness, so you have a lot more systemic symptoms. And then the urticaric rash that you see above. And then type 4 is a delayed type reaction, and that's a cell-mediated hypersensitivity, which results in a contact dermatitis. And so that is kind of shown below. And those are the most common drug eruptions. It's delayed. People can have been on drugs for a while and develop these. More commonly, they're going to have started it fairly recently and have a poor reaction to it. So the most common medications to cause drug eruptions would be antibiotics by far. And the antibiotics, pretty much every single one, you see the list, it's all of them can cause it. And then you can get drug eruption from getting whole blood or packed RBCs, also from anticonvulsants or antiepileptic medications. Non-steroidal anti-inflammatory drugs can also cause this. And then captopril, furosemide, thiazide diuretics. And honestly, pretty much every drug can cause it. And I think these come up on multiple lists because they're the most commonly prescribed. And then the mobiliform, which is shown in this picture, that's considered a mobiliform rash, and it's slightly more raised, looks more like a bunch of little dots all together that are slightly raised. Those are specific to the medications listed. So you can try to differentiate if you see a rash that looks a little bit different, and then you can identify it, then that can be helpful. So the diagnosis from a drug eruption, like the other ones with dermatology, it's very much based on finding out if they've started a new medication or if they've had recent changes to their medications. Another question that I ask is, do they get them from the same pharmacy? Sometimes they have a compounded medication. It can be compounded slightly different, or a generic can affect them different. So a really good history on these. You can biopsy the skin, look for certain findings like eosinophils or increased IgE, but difficult. if you see this patient, if it's a small rash and you're like, I think it's just this, and you have a good history, you don't necessarily need to do any labs. If the patient appears slightly more ill or you're unable to identify any clear cause, you might want to check some blood work to make sure they don't have any renal or liver involvement. So the most important treatment for this, pretty much the only real treatment, is to identify the drug that's caused the rash and eliminate it. For slightly more irritating, like severe drug eruptions, you can use antihistamines, so Benadryl or Claritin, and then you can use topical or oral steroids. Oral steroids have not shown to be very beneficial, and they do have quite a few side effects. So typically topical steroids will work for these. If it's really extensive and you can't prescribe topical steroids, somebody can't use topical steroids all over everywhere, they'd be getting too much absorption of the steroids. So if you're getting to a point where it's extensive involvement, then you can use oral steroids for these patients, and that's to treat their symptoms. If the patient's reaction is severe, so over a huge amount of their body, if there's involvement of their mucous membranes, if they have any abnormal labs, if it's limiting their ability to eat or drink, then those patients may end up needing to be admitted. But usually these ones you can treat and they can go home. And then if you're admitting them, you can also use IV steroids, something to really hit them. Next category going to be purpuric rashes. So these ones, you can see them, they can be kind of more minor or they can be extensive. And we'll talk about one purpuric rash next week, which is meningitis. The ones we're going to talk about this week are non purple. It looks almost like bruising underneath the skin. They usually are non-blanching. It's just like that purple skin like you see, and you guys have all probably seen it. The lesions are usually, if they're less than 2 millimeters, it's just called petechiae. If they're between 3 and 9 millimeters, it's then purpura. And then greater than 10 millimeters is ecchymosis, or a true bruising. So those are kind of the defining characteristics. For our point, purpura is just right in the middle, it's fine. The differential diagnosis, like I said, meningitis, but benign petechia, just you can get this from vomiting or straining, you've seen it around the eyes. Then immune thrombocytopenic purpura, thrombotic thrombocytic purpura, TTP, IgA vasculitis, Henoch-Schönlein purpura, or HSP, which is very common in children, or much more common, heparin-induced thrombocytopenia, or HIT, hemolytic uremic syndrome, HUS, or disseminated intravascular coagulation. And today we're just going to talk about a couple because some are seen more predominantly in pediatric patients, which you guys aren't seeing a ton of, and then others are going to we won't totally discuss heparin-induced thrombocytopenia because it can be pretty obvious the patient has to be on heparin, so the history should be easier to get theoretically. So purpura, if you see purpura, this can be secondary to such life-threatening disease processes that you need to be on high alert for these patients. They are oftentimes ill, or if they're not ill in front of you, they will decompensate and become very ill. So take good care with these patients, and then you're going to want to diagnose and figure out what's going on. So these patients will all need CBC, look at the platelet count. Platelet count can be very definitive for this, a PT-INR, and then a PTT, fibrinogen levels, a D-dimer, CMP, blood cultures, and a lactate, especially if they're ill appearing. And the treatment is really dependent on the diagnosis and the severity of the illness. So one thing we'll talk about, and I kind of wanted to hit on it because it's not something you probably talk about in other sections, but you will see it, and if you can identify it early, it's really great. So thrombotic thrombocytopenic purpura. So this is caused by a platelet aggregation and thrombus formation in the microvasculature, and it will lead to a hemolytic anemia, so body destroying red blood cells as well as platelets, so severe thrombocytopenia, and then oftentimes organ ischemia. The people will present with petechiae, purpura, this like you're seeing mucosal hemorrhaging. And then if they've become anemic, it's gotten to that point, they will appear more ill. They can be tachycardic, hypotensive. They don't usually have extensive bleeding, so that's something to remember. The TTP can start to involve organ systems such as the central nervous system, the GI tract. So you can get other manifestations as listed, like altered mental status, headache, vomiting, diarrhea. So the distinguishable labs on CBC, you will get a decreased platelet count, which is true in pretty much all purpuric diseases. But on a peripheral blood smear, you would see schistocytes. The INR, PTT, fibrinogen are all going to be normal, and then you can have an elevated lactate dehydrogenase. If you're able to identify this and you're pretty certain this is what it is, you could consult your hematologist, and then the treatment would be a plasma exchange, and then you need a dialysis as well when you're doing plasma exchange. They'd need to be somewhere where they can get dialysis. The only time that and then you can also, if you don't have the ability to do plasma exchange, which is a lot of places, you can administer fresh frozen plasma, and then you can also give prednisone. And then otherwise you're doing supportive care. You only want to transfuse platelets if there is a hemorrhage and it's life-threatening, because when you give platelets, their body just eats them, and then that makes the disease process worse and can lead to further organ damage. So you really only use platelets if you absolutely have to. So that, sorry. So that is it for thrombotic thrombocytopenic purpura. And that's really the only one that I was going to talk about, because the rest I'm hoping like you'll see in other sections, DIC, these people are very ill. And when you see DIC, you need to look at all of their coagulation studies and be on high alert. So all these purpuric rashes, just know that these patients are likely to have a life-threatening or serious disease process. And this will be kind of our last thing that we touch on. So skin cancers, and not gonna dive too much into this either, but if you see a patient for this cause or something else, and you see these, you should be able to identify this. Yes, it's not our predominant job in the ER to identify and diagnose skin cancers, but in some cases we're the only doctors that patients see. So if they have other concerns, if they have a malignancy that you find and diagnose, and you're looking for the primary, it's not a bad idea to do a thorough skin exam and look for any abnormal lesions. If you can if you can diagnose it early in a patient, you can save their life, because this can be a very deadly disease. So the first one is a benign skin cancer. That's a squamous cell carcinoma. These are non-malignant and they don't often spread. And that is usually the appearance more skin colored, more round. They don't stick out as much. The only way to really differentiate these is to do a biopsy and have them evaluated. But if you see any of these things and they look slightly concerning, then you can refer them then to dermatology or somebody that can help with that. The next one would be a basal cell carcinoma, and these tend to be like a little bit darker, slightly more raised. These are usually non-malignant, so they won't spread, but they do need to be removed, and it can be a precursor to melanoma. The last is melanoma. So obviously the most significant diagnosis. Melanoma is deadly. It is malignant, high likelihood for spreading into the underlying lymph nodes, and then that can spread throughout the rest of the body. So the distinguishing characteristics of a mold that would distinguish it and like make you think of melanoma is if it's asymmetric. So if it's just not a clear round, you can see that if there is an abnormal border, so if it's not clear, it kind of like skews out into the outside of it. If there is uneven color throughout the lesion, if the diameter is larger than 0.25 inches or 4 millimeters, that's concerning. And then if it's changing, so if it's evolving. So if any of those characteristics are true, if you see anything, then you should be highly suspicious. Some places I have seen ER doctors actually biopsy highly suspicious. They just like clean cut it out and then throw a little suture in it. If they're really suspicious, and send it to lab. I don't know if you have that ability. I don't know if I would do that. Just not an option. So that is it for this week, and I'll just kind of show you guys real quick. So skin cancers, we got them. Our purpuric rashes, highly suspicious, usually very terrible. Then drug eruptions is the mabiliform rash. There's your urticaria, your urticaria as well for the type 3, and then cytotoxic reaction, and then delayed reaction. Stevens-Johnson and toxic epidermal necrolysis, and then erythema multiforme. So that's it for this week. And then next week, we'll kind of dive into some infectious causes of rashes, which there's more, but we'll just talk about the really prevalent ones and ones that we should be able to identify and that are really important, not all of them. And yeah, any questions? Can you guys hear me? Will you just write in the chat that you can hear me? I know we're done, but I can't. I was looking at my phone to see if I don't know if my internet is bad or something. Oh, good. I hear somebody. Okay. I was just making sure. I can't see anybody. I don't know. I think I have bad internet right now because there's a storm here.
Oh, there's a storm in your region?
Yeah, right now. It's just raining.
Yeah.
It's not that bad, but
Yeah. So do you have a separate lectures about dermatologic manifestations of some infection disease, like some patient with sepsis? They have some special size of special size in your skin, on your skin. Then we can identify. Do you have a lectures for that?
yeah, next week we'll talk about infectious critical rashes. This week, yep, I just wanted to break it down into non-infectious because then it's a little easier to distinguish if somebody's not sick with, viral illness or fevers, things like that. So these are the rashes not usually associated with infections that don't present with fever or other, symptoms that you would have if you have an infection. And so they'll just to differentiate in that way. So next week we'll talk about rashes that come with infections. So, I think here I'll tell you. Yep. So we'll talk about, and if I'm still working on the lecture, so if you guys have anything specific you want to, but I was going to talk about meningitis, measles, chickenpox, anthrax, leishmaniasis, monkeypox. Were kind of what I was going to hit on next week.
It seems interesting. Yeah, we also have some pictures about dermatologic manifestations of some infection disease, like streptococcus,
Mm-hmm.
It is very special.
Yeah, definitely. And it's good to like, I mean, I have to review those all the time also because if you're not seeing them all the time, and rashes can be really hard to identify. It's like something that takes continuous practice because it can be really hard to differentiate different rashes.
Yeah,
Um,
definitely. Yeah.
yeah. Well, yeah, dude. So I will next week. I'm gonna send out the next week will be the last of this month that I'm doing. But yeah, so next week infectious causes, and then if you guys, I'll send out this lecture too, and when it's done like last time, and so then you can always review it if you ever need to. But and then in the next like day, if you have any pictures, specific pictures you want to see, then you can send them, and we can next week we'll kind of just hit on more of the more pictures and more diseases.
Yeah. Um, okay. I'm eager to learn
Yeah.
to your next lectures. And if I will collect some pictures that's
Okay.
in my phone, then we can
Sounds good.
share during our lections.
Okay, perfect. Okay, bye guys. Well, thank you.
Thank you so much.
Thanks.